Right. The great news is they have found my talk. I don't know if it's great news. Hopefully people will think it is. But I think we have the right one here, and we're going to continue on. So I'm going to be talking about some advances in port wine birthmark treatment. There we go. Okay. I'm going to talk a little bit about large area OCT mapping. I'm going to talk about long pulse 532 versus pulse dye laser. Both of these topics have been brought up this morning. I think that's great. I want more people to know about it and have these possibilities. And then I'm going to talk about the GNAQ mutant endothelial cell distribution in port wine birthmarks and what that may mean for the future of port wine birthmark treatment. Now, optical coherence tomography, we've been using on most of our patients now. We've been doing this for about 5 years. I think about it as kind of like an ultrasound, but using light instead. It gives us images. We can use it for diagnosis, for example, of a basal cell carcinoma, but in particular in my clinic, I use it to look at vascular birthmarks and to characterize them better. It takes about 30 seconds. I can get to a depth of over 1 millimeter. There is some decrease in the resolution compared to, for example, multiphoton microscopy, which is almost like your histology, but it can give us some very important information. For example, we can get, let's see if I can get this here, we can get the it's a 30-second measurement, we push a button, and then we can get the superficial plexus depth, and we can get the modal vessel diameter and density. Now, when we started doing this on each patient, we'd do 1 or 2 little spots to get some information about their port wine birthmark. Now, we've seen that there's just huge variability, and we've known this for a long time, but we've really been able to show it with optical coherence tomography. So now we're doing this large area mapping where we might do 20 or more spots on a patient to cover their port wine birthmark. And we have software that allows us to look at these spots, either in aggregate or individually at different depths, starting at 0.15 millimeters, where we start to see those vessels. We have also learned that each individual is different, not only in their port wine birthmark, but just their overall vessels. So we also use uninvolved skin. We take a measurement there, and then we make a ratio. Now, I'm just going to give you a really quick summary of some of the things we've been looking at, but looking at 15 lesions here, we found initially that the only depths where density of vessels was consistently greater in affected skin compared to the control skin was at shallow depths, 0.15 to 2 millimeters. And we didn't see any observed pattern of vessel diameter with depth. When we looked a little bit further, we saw that in a flat port wine birthmark, again in our 0.15, actually up to 0.3, we did see increased density. And then when you looked at hypertrophic port wine birthmarks, we saw that to a deeper level, and then hypertrophic port wine birthmarks with nodules, we saw it to even deeper level, down to 0.5 millimeters. So I do think that there are different characteristics, and there are some overall ideas that we can get from this, but I do want to really emphasize that these port wine birthmarks are very individual, and even spot to spot is very different. It's I will say, a tangle of blood vessels, basically. Now, there are always limitations to looking at things. One is that relatively small sample size. In this particular one, we didn't have very young children, although I will tell you this doesn't hurt at all, and it takes us 30 seconds. We play the baby shark video, and we're able to do it for 30 seconds for most of our even small infants. Right now, we can't measure vessels that are less than 20 micrometers, and if they're really low flow, then sometimes the information is not as accurate as we would like. So I think that there are going to be things that we can continue to do, but I think that this is really going to ultimately give us some information. As I mentioned, we did see that the highest blood vessel density was at 0.15 to 0.2 millimeters. This may mean that we don't need to use the deepest wavelength for many of our port wine birthmarks. I'm not saying for all. I think there are definite ones that we may want to do that, but for many of our lesions, we may be able to use our 532 or 595 nanometer wavelengths. Now, another thing I wanted to briefly talk about is 532 versus 595. Of course, we've had both of those wavelengths for a long period of time, but recently we've been looking at a newer model of this, which has cryogen spray cooling, and comparing those two. We did both a clinical assessment, looking at the pictures pre and post, and then we also were able to get some information from the patients in terms of comfort. And basically, I'll show you a couple pictures here in different conditions, but basically we found that we could achieve equal results with either one. Here we have a port wine birthmark. You can see there happened to be a little more in purpura with these particular settings. This is courtesy of Dr. Graywall, who is also at the University of California, Irvine, but roughly equivalent clearance. Here's a port wine birthmark patient that I did. You'll note that with the 532, which is the LP there, the long pulse 532, that I used a 10 millisecond pulse duration, so it's not surprising, but I had a little less purpura with that, but equivalent clearance, so I think both can achieve a nice result. And here's a patient with rosacea who I've now done multiple treatments on, really half of their face with the pulse dye laser, half of it with the long pulse 532, and really equivalent results. Now, with some of the patients, we found that the pain or discomfort was a little bit less with the long pulse 532, but again, we're looking at sometimes different settings. A lot of people report more swelling or edema with the long pulse 532, although I have to say with the settings I've been using, I have not seen that so much. They've been roughly equivalent. Redness afterwards has been equal, and in some patients, there's been slightly less purpura, again, probably due to the settings that we're able to use, but still get very nice results with the long pulse 532. Lastly, I wanted to kind of look to the future. You know, we know that port wine birthmarks, the major genetic change is a GNAQ mutation. There are other ones, and we could talk about that at another time, but thinking about this, part of the problem is, though, we know those are mostly in the endothelial cells, but the question is, what's the distribution of those endothelial cells that have the mutant GNAQ? And that's something we don't know anything about, really. It could be that certain blood vessels, all of the endothelial cells have a mutant GNAQ. It could be that it's scattered, as you can see here in the picture. And then it could be that all of one vessel has it scattered. It could be that a little portion of the vessels have it. We really don't know. There are new technologies, spatial transcriptomics, where people are trying to look at this, but these are very difficult to get down to this resolution of these individual cells within a blood vessel. So the truth is we don't really know. Now, with our pulse dye laser, we never remove all the vessels. That's part of the reason, actually, that it's safe, right, is because we have vasculature that's going to prevent us from causing significant necrosis and scarring. But it also means that we're never going to get all of those mutant endothelial cells, most likely, with our current way of doing it. With photodynamic therapy, we can wipe out all the vessels, but of course, if you wipe out all the vessels, then you get necrosis and scarring. So neither of those are going to be ideal. So future directions, we certainly have tried adjuvant medications in the past, like rapamycin, imiquimod, and timolol have all been tried. Some potential benefit was seen, but most of us are not doing that now because it didn't show enough benefit. So the question is, most of these were probably anti-angiogenic medications, but could there be other medications that are really more targeting this pathway? I think that is going to be the key. We need more research to understand what happens downstream of this activated GNAQ. We need medications that specifically target this pathway of pathogenesis. And then people are probably going to have maybe a laser treatment, then followed by medication, and probably long-term therapy with this to maintain it. So in summary, I think OCT is providing us a lot more information about individual port wine birthmarks. I think ultimately we're going to be able to use that to really make our treatment better. We have newer devices that provide additional option, but I do think that laser alone may not be the answer here. I think we're going to have to combine laser with our science in order to get the best outcome. Thank you very much for listening and your patience this morning.